If you combine Tea Time Episode 10 evaluating mitral regurgitation with Tea Time Episode 11 evaluating mitral stenosis and add as much high-yield, clinically relevant material as possible, well, I give you Tea Time Episode 12, what every healthcare provider should know to perform TEE with excellence in mitral valve replacement surgery cases. Welcome to Tea Time. I am Dr. Andreas Plakis, and in this episode 12, we're going to be talking about all things TEE for mitral valve replacement surgery cases. The clinical question that we're going to be addressing is how can a clinician use TEE to provide best care for patients undergoing mitral valve replacement surgery? The material that we're going to cover in this episode is really a culmination of several different episodes. We'll cover the material in pre-bypass, intraprocedural guidance, and post-bypass periods. But you'll notice in the pre-bypass period, it's basically a summary of episodes 9, 10, and 11, the 6-step native valve evaluation, how to evaluate MR, and how to evaluate mitral stenosis in a summarized format. And then in the post-bypass period, we're going to review how to evaluate the newly replaced mitral valve. So we'll start with the pre-bypass period first. As I've talked about numerous times already, there's a 6-step evaluation for native heart valves that I went over in Tea Time Episode 9. We're going to use this structure in a very high-yield summary of how we perform this for mitral valve surgery cases. It's important to see mitral valve surgery cases through the context of the indication for the procedure. In the 2020 ACC/AHA guidelines for management of valvular heart disease, there are several different indications for mitral valve surgery, but the broad categories are for severe chronic primary MR, severe chronic secondary MR, severe rheumatic mitral stenosis, progressive rheumatic mitral stenosis, and calcific mitral stenosis. I'm not going to go over all of these details. This slide is mostly here in case you want to take a screenshot for reference for future surgeries or to keep track of all these indications in one concise location, but keep these in mind whenever thinking about the big picture here. The first step in the 6-step of native valve evaluation is looking at clinical information. The first part of this is looking at patient symptoms. That is a major differentiator in all the treatment algorithms for mitral valve surgery indications. Are they asymptomatic or symptomatic? I'll make sure to take note of their heart rate and blood pressure at the time of the TEE exam. For mitral regurgitation, hypertension can make a regurgitant jet look even worse, whereas hypotension can actually improve a pretty significant MR jet. For mitral stenosis patients, guidelines recommend evaluation between 60 and 80 beats per minute, and heart rates higher than this can increase the gradients through the mitral valve. So that's important to be aware of because it may make the mitral stenosis severity look even worse. Also, taking all the pieces of clinical information into the context, the patient under anesthesia can have decreased preload and afterload, both of which can improve MR severity. So make sure your MR severity assessment is as close to physiologic awake conditions as possible, whether that necessitates a fluid bolus or getting the blood pressure to where their resting blood pressure is at an awake state. Those are some of the interventions you can perform here. Step 2 for patients with mitral valve pathology involves using the use of 2D echocardiography to assess leaflet structure and function. The purpose of evaluating leaflet structure and function is discerning if the patient would benefit from mitral valve replacement or if they're a repair candidate instead. It also helps identify risk factors for mitral valve repair failure, such as for primary MR, certain SAM risk factors, or for secondary MR if they have associated tethering and tenting of the mitral valve that's very severe. For mitral regurgitation patients, you always want to walk away saying you know 3 things: the mechanism, the location, and the severity of the MR jet. Is it primary versus secondary MR, where you know the Carpentier class as well? Can you discern the exact location of the leaflet pathology? And then can you apply that 2017 ASE algorithm for native valvular regurgitation to determine the severity of the valve being mild, moderate, or severe regurgitation? For mitral stenosis, I want to determine the etiology of the mitral stenosis, as different etiologies have different repair or replacement strategies. Is it rheumatic? Is it calcific? Or is it another different type of etiology altogether? Also, if there's significant calcification, that can add complexity for the surgeon when performing mitral valve replacement. My approach for evaluating the mitral valve is very simple. I start with a mid-esophageal commissural view. I will explain through this and then have a long axis view where I look at A2 and P2 leaflet pathology. Then I'll slide my X-plane more laterally to look at A1 and P1, and then finish by sliding more medially to look at A3 and P3. I'll do this all with and without color, and with that, I should be able to determine the mechanism, location, and severity of any leaflet pathology and get a good idea of leaflet structure as well. If I'm unable to see with that system exactly what I need to see, there are other views available that I would go to further evaluate the mitral valve as well. Keep in mind, with 2D echocardiography, there are many different types of pathology you may encounter, and the easiest way to think about these is by Carpentier class, dividing them into type 1, type 2, and type 3. Normal leaflet motion, excessive leaflet motion, and restricted leaflet motion. Step 3 in your mitral valve evaluation will consist of Doppler echocardiography. I divide this into color Doppler and spectral Doppler. For color Doppler, when I'm assessing mitral regurgitation, I want to look at several different components of the jet. First, the site and direction of the jet is very important, whether it's eccentric or centrally directed jet. And then the jet components specifically are the size of the jet area, the size of the vena contracta, and the presence of a large flow convergence. When you assess mitral stenosis with color Doppler, you may see a large proximal flow convergence on the left atrial side of the valve, and then turbulent flow after the mitral valve. Also, there's tools we can use with spectral Doppler. When evaluating mitral regurgitation with continuous wave Doppler, you can look at the contour and density of a jet. And with pulse wave Doppler, you can look for pulmonary vein systolic flow reversal and look at the transmitral inflow and the E and A waves specifically there. When evaluating mitral stenosis, you can use continuous wave Doppler to evaluate transmitral mean pressure gradient, and also use continuous wave Doppler to evaluate pressure half-time, as both of these are level 1 recommendations when evaluating mitral stenosis. Step 4 in your mitral valve assessment will consist of quantitative measures. For MR severity, one of the tools you can use is PISA. And as I've alluded to in previous episodes, I don't like using the PISA calculation because I think it's prone to error. However, using the PISA radius being greater than 1 centimeter at a Nyquist of 30 to 40 centimeters per second is a helpful and quick tool that you can use that is one specific marker for MR severity. Also, for mitral stenosis patients, using 2D planimetry and that transgastric basal short axis view is important. Keep in mind with this, it's important to get the actual 2D planimetry at the leaflet tips where the smallest mitral valve area will be. That is your true mitral valve area. You could also do PISA and continuity equation calculations, but I do not recommend these as they are cumbersome and other tools are easier to perform and more reliable in these patients. Step 5 is using 3D echocardiography to assess the mitral valve. We've gone over both these strategies in previous episodes in more detail, but for mitral regurgitation patients, use 3D vena contracta area to assess the EROA, or use 3D planimetry to assess mitral valve area in mitral stenosis patients. Using 3D can help you localize specific sites of valve pathology, so always keep that in mind when using 3D as an additional complement to 2D echocardiography. The last step, step 6 in our pre-bypass mitral valve evaluation, will consist in looking at all the other cardiac data that could be relevant for the surgery. Looking at LV size and systolic function, LV size can dilate over time with chronic mitral regurgitation and volume overload. The function can appear normal, but because there's significant regurgitant volume in an MR jet, normal LV ejection fraction does not always indicate normal cardiac output. Lastly, in regards to LV, you'll want to get a baseline regional wall motion assessment. One of the main complications of the surgery can be injury to the left circumflex artery, which can cause regional wall motion abnormalities. So knowing what is normal beforehand can aid you when you come off cardiopulmonary bypass after the valve has been replaced. We'll also assess the left atrium and left atrial appendage. We would expect the left atrium to be dilated in chronic mitral regurgitation and chronic mitral stenosis patients. And this makes patients prone to atrial fibrillation as well, which is why we'll also want to check the left atrial appendage for thrombus. We'll look at RV size and systolic function, and also pulmonary hypertension as well. These patients have pulmonary hypertension because of the increased left atrial pressures causes this WHO group 2 pulmonary hypertension from left-sided heart disease that causes back pressure through the lungs and on the right side of the heart system. So this increased pressure on the RV and the RA cause dilation and dysfunction, which can also lead to functional tricuspid regurgitation as well. We'll assess our aortic valve pre-bypass in these cases because the aortic valve is at risk of injury because of its close proximity to the anterior mitral valve leaflet. Remember as well in mitral stenosis patients that bad aortic stenosis can lower the flow artificially across a mitral valve because of low flow states. Also, if there's severe mitral stenosis and there's a low flow state from that, it can artificially lower the gradient across the aortic valve. So these two can affect each other when there's significant severity from one interacting with the other. Also, significant aortic insufficiency can make pressure half-time measurements invalid. Lastly, when looking at other cardiac data, we'll assess the tricuspid valve as well. Moderate TR without a dilated annulus, which would be less than 4 centimeters, often improves after mitral valve surgery. However, if there's progressive TR with either tricuspid annular dilation over 4 centimeters or prior right-sided heart failure symptoms, that's a Class 2A recommendation for tricuspid valve intervention at the time of mitral valve surgery. Next, we'll look at some of the intraprocedural considerations when a patient undergoes mitral valve replacement surgery. There's numerous different types of surgical approaches to the mitral valve during mitral valve replacement surgeries. These include both entry into the chest and entry to the left atrium to access the valve. Entry into the chest, you can perform a full sternotomy, a minimally invasive approach, which would be a mini thoracotomy or robotic surgery or partial sternotomies as well. There's also transcatheter approaches to replace the valve, but we're not going to cover that in this episode. We will cover that in future episodes of Tea Time. The relevance for the approach through the chest for the surgeon is that minimally invasive approaches are frequently more TEE intensive. You may guide more wires, cannulas, cardioplegia catheters. Just keep that in mind. That's why it's important from an echo perspective, why you need to know the surgical approach to the chest. In regards to minimally invasive approaches to mitral valve replacement surgery, there are a handful of things you can do with TEE to help the surgeon, both with cannulation and cardioplegia strategies. The first of these is the femoral venous cannula. You're going to obtain a mid-esophageal bicaval view. As that wire is placed in the femoral vein, you will see the guide wire coming up into the right atrium from the IVC and engaging in the SVC. You want to make sure it's not going across the inner atrial septum or into the right atrial appendage. Also, when that femoral venous cannula is passed up over that wire, make sure it enters the right atrium and engages the SVC and does not enter any of those structures we just mentioned. Some of the things that can happen here is where that wire is either not in the venous system or it gets stuck in the IVC or going down a hepatic vein or other vein. When helping guide the femoral arterial cannula placement, it's very common that you will not be able to see that femoral arterial cannula at all as it's too low in the patient's body, but you will be able to see that femoral arterial wire placed in that femoral artery and up into the descending aorta to confirm that the placement is arterial. In regards to cardioplegia strategies, you can help by guiding that retrograde cardioplegia catheter. You'll want to visualize the coronary sinus and see that inflated coronary sinus catheter balloon in the coronary sinus. And when you're on cardiopulmonary bypass and you're administering cardioplegia with that balloon up, confirm the absence of flow around that balloon and see it only being administered downstream from that catheter tip. You can look in two different main views for this, either the mid-esophageal modified bicaval view or the deep esophageal four-chamber view to see the coronary sinus well. Also, there's other strategies out there. We're not going to go over them, but certain things like endo balloons, floating your own coronary sinus catheter via the IJ, or other strategies are other things that can occur in these minimally invasive mitral valve replacement surgeries. Now let's focus on things we should know for the post-bypass period when we're coming off pump in mitral valve replacement surgery cases. We're going to apply in the post-bypass period the material that we went over in episode 8 of Tea Time, the newly implanted heart valve, the slick System. This is a 5-step system. SLIC is an acronym where we go over 5 different things we need to look at with the valve and also in other parts of the heart to ensure that the valve was implanted and working correctly and that other parts of the heart are functioning as they should be. The first part, the S in SLIC, is the sewing ring. We want to image the entire sewing ring first at the mid-esophageal level. Start at 0 degrees and sweep all the way to 180 degrees at 30-degree increments to make sure that sewing ring is stable. In this echo clip, you see what it looks like for a mitral valve to be very stable, where the sewing ring is well seated. But for the aortic valve replacement that was performed in addition to the mitral valve replacement, that aortic valve is rocking. That is not what you would want to see in the mitral position. Keep in mind that heart chamber movement can fool your eyes. There's atrial contraction. It moves the mitral annulus. But one thing to remember is that with rocking and instability come paravalvular leaks. So if you don't see any PVLs, that rules out significant sewing ring abnormalities. Step 2 in the SLIC evaluation, the L stands for leaflets. We're going to evaluate the newly implanted mitral valve leaflet motion. Normal leaflets open and close. It's that simple. It's black and white. They open and close. Abnormal leaflets either do not open or do not close. This causes a bioprosthetic valve to either have stenosis or flail and prolapse leaflets. Also, a mechanical valve can have immobile leaflets as well. There could be something structural in the way keeping those leaflets from opening, or it could be a defective valve altogether. The I in the SLIC valve evaluation stands for insufficiency. Look for normal jets and pathologic jets. Normal jets would consist of trace central jets in bioprosthetic valve, or these washing jets, these small, homogeneous, uniform color jets that you would see in these mechanical mitral valves. Pathologic jets can be divided into intravalvular or paravalvular. Intravalvular jets are anything inside the sewing ring that would be mild or greater, that should not be there. Paravalvular jets are a little bit more complicated to assess, but anything outside the sewing ring is a paravalvular jet and is abnormal. I assess paravalvular jets by starting in the mid-esophageal four-chamber view and scanning from 0 degrees to 180 degrees, stopping every 30 degrees with color Doppler. You can sometimes even localize these paravalvular leaks with a 3D en-face view, and that can help inform the surgeon exactly where that paravalvular leak would be located. Trace and even mild PVLs can be somewhat common after these surgeries and are frequently hemodynamically insignificant and improve over time with either protamine or just with time itself. However, moderate or severe PVLs should trigger surgical reintervention. The C in the SLIC valve evaluation stands for collateral injury. This is where you want to think what structures are close by anatomically to the mitral valve that could have been injured at the time of surgery. This would include the left circumflex artery, the aortic valve, the coronary sinus, the conduction system or AV node. For collateral injury assessment, look at LV systolic function, and in particular, looking for regional wall motion abnormalities, as a regional wall motion abnormality in that lateral, infralateral segment could indicate the left circumflex injury. Frequently, there's a suture that can compromise that left circumflex artery around the annulus. Also, to round out our ventricular assessment, look at RV function to ensure that there's no stunning that occurred from the time spent on cardiopulmonary bypass. In addition to ventricles, we're going to look at valves that could have been injured as well. We're going to assess to see if there's any new or worsened aortic regurgitation. There can be suture damage because of the close proximity of that anterior mitral valve leaflet to the non-coronary cusp and the left coronary cusp of the aortic valve. Those sutures can catch part of the aortic valve and actually cause new regurgitation. Also, we'll assess the tricuspid valve. As we mentioned, sometimes these valves can be addressed at the time of a left-sided heart surgery like a mitral valve replacement surgery, and we'll look to see if there's improvement in the tricuspid regurgitation either with or without intervention being performed. There's a few other miscellaneous things we'll look at in the collateral injury category. Anytime a patient had a cardiopulmonary bypass run, we'll want to make sure that there's no dissection seen in the aorta after the fact and after you're off cardiopulmonary bypass. We'll want to assess the interatrial septum as well, as some surgical approaches can accidentally leave an iatrogenic ASD. Lastly, we mentioned patients with mitral valve pathology can have atrial fibrillation, and so frequently these patients will have left atrial appendage clips or occlusions. Make sure that there is successful clipping at the time of mitral valve surgery, that there's no or minimal residual flow in there, that there's an appropriate stump length to ensure that the patient is at reduced risk of thrombus at that location. And then the K in the slick valve evaluation is looking at kinetics. It's looking at hemodynamics. How is the flow through the valve? And really, it's important here to exclude any iatrogenic mitral stenosis. The most important measurement is getting a mean pressure gradient. Also, if needed, if we're really worried about stenosis, we can get 2D or 3D planimetry as well. After we've finished our slick valve evaluation, we'll perform a full TE exam at that point. Remember, the slick system is what you need to do before we give protamine and start removing our cardiopulmonary bypass cannulas. It's a very concise and efficient system to rule out the most important things for the surgical team to keep progressing with their surgery. But also, just to make sure we don't miss anything else, we want to perform that full exam after the slick system has been completed. Additionally, if you have any new or worsening clinical changes, you want to start over at the beginning of that slick system and do it one more time, as that can quickly identify any new abnormalities. So let's summarize this episode, how to perform TEE for mitral valve replacement surgery, with a few key points. Point number one, in the pre-bypass period, we have a 6-step native valve evaluation system that can give us a framework to guide surgical decision-making in the pre-bypass period. Step two, know the surgical approaches to the chest, cardioplegia, cannulation strategies, as knowing this can help us guide wires, cannulas, catheters intraprocedurally. And step three, in the post-cardiopulmonary bypass period, use that slick valve evaluation system to assess that newly implanted heart valve. All right, next episode, we're taking it up a level. Episode 13 will be TEE for mitral valve repair surgeries. We're going to cover things such as when to repair versus when to replace the valve. What are certain surgical repair strategies and what you need to know from the surgical side? And then how do you avoid repair complications that you may see? Here are references. Thank you guys for watching. Feel free to hit that subscribe button if you want more of this content and you want to make sure that new episodes as they're released get right to you. Also, feel free to leave us a review, leave us a comment. That is how we get that information that is in these episodes out to more people. So check us out on social media as listed right here. And again, thank y'all for watching. We'll see y'all next time.